everybody, and welcome. It's a pleasure to welcome all of you to this 25th session of the ESHRE meeting entitled Determinants and Intervention for Short-Term Outcome. Before we begin, please two remarks. First, switch off your mobile devices to silence, and taking photographs, not use any light, okay? The first presentation is entitled Impact of Conception Method and Endometrial Preparation on First Trimester Uterine Artery Doppler and Preeclampsia Screening. It's presented by Lee VT.
Good afternoon, everyone. I'm Dr. Lê Văn Thành from Medoc Hospital, Ho Chi Minh City, Vietnam. It is my honor to be here today to present our study about the impact of conception method and endometrial preparations on first trimester uterine artery Dopplers and preeclampsia screening. So, UTAPI is an important component of preeclampsia screening. In general, high UTAPI mean high uteroplacental resistance and means high preeclampsia risk. On the other hand, pregnancies after frozen artificial cycles have no corpus luteum. This can alter the maternal vascular adaptations and also increase the risk of preeclampsia. So logically, we might expect UTAPI to be higher in this group. However, many observations show the exact opposite. UTAPIs may actually be lower in frozen artificial cycles. This paradox may cause current screening algorithms to underestimate the true risk of these pregnancies. Based on these rationales, we conduct this study in order to evaluate the associations between conception methods, endometrial preparations, and first trimester UTAPIs. For the primary outcomes, we compare first trimester UTAPI across 5 conception groups: the spontaneous conceptions, the ovulation inductions, intrauterine inseminations, the IVF fresh embryo transfers, the frozen natural cycles, and the frozen artificial cycles. Secondary outcomes include aspirin prophylaxis prescriptions, the preeclampsia incidence, and the factors associated with first trimester UTAPI. So this was a retrospective cohort from Medoc Hospital between 2020 and 2024. We include in total 4,212 singleton pregnancies, 2,947 from spontaneous conceptions, 42 from IUI, 30 from IVF fresh embryo transfers, 124 from frozen natural cycles, and 1,069 from frozen artificial cycles pregnancies. All of these women underwent first trimester preeclampsia screening and complete antenatal follow-up with delivery at our hospital. For the screening protocols, the uterine artery Dopplers was performed between 11 and 13 weeks, 6 days by FMF certified sonographers. Preeclampsia risk was calculated using the maternal factors, the mean arterial pressures, the placenta growth factors, and the mean first trimester UTAPI. Women with risk greater than or equal to 1 in 100 receive aspirin 162 milligrams daily until 36 weeks. So this is the baseline characteristic of our study populations. The maternal age in frozen embryo transfers groups were significantly higher compared to spontaneous conceptions and the IUI groups. Weight and BMI also differ statistically, but the absolute difference was small. Parity distribution were also different, with a higher proportions of secondary parity. However, fetal parameters such as nuchal translucencies and crown room length were similar, suggesting that the timing of first trimester assessment was well balanced. Moving to the primary outcome, this figure shows the distributions of first trimester UTAPIs across 5 groups of conception methods. Mean UTAPI was 1.7 in spontaneous conceptions, 1.8 in IUI, 1.7 in IVF fresh, 1.6 in frozen natural cycles, and lowest in the frozen artificial cycles at 1.4. The overall difference across groups was statistically significant. The adjusted pairwise heat maps also confirm the same patterns. Compared with frozen artificial cycles, mean UTAPIs was 27.3% higher in spontaneous conceptions, 30% higher in the OI-IUI groups, and 22.9% higher in IVF fresh, 17.5% higher in the frozen natural cycles. All of these comparisons were statistically significant after 2K adjustments. Aspirin was prescribed more frequently in pregnancy with assisted reproductive technique. The reproduction rate was 3% in spontaneous conceptions, compared with 9% in frozen natural cycles and 10% in frozen artificial cycles. Although the frozen artificial cycles receive aspirin more often than spontaneous conceptions, aspirin use was almost identical between the 2 frozen transfer groups. When we look at the actual preeclampsia incidence, the highest rate was observed in the frozen artificial cycles. This compared with the highest rate at 3%. This compared with 2% in frozen natural cycles and 1% in spontaneous conceptions. There was no case in the OI-IUIs and the IVF fresh groups, but the group's sample was small. Overall, frozen artificial cycle had the lowest UTAPI, but the highest observed preeclampsia incidence. In the multivariate analysis adjusted for maternal age, BMI, and parities, frozen artificial cycle remains the strongest factors associated with lower UTAPI, with an adjusted ratio of 0.79, meaning about 21% lower than spontaneous conceptions. Frozen natural cycle shows a smaller but also significant reductions at 0.92. Our findings are consistent with recent studies. In our studies, frozen artificial cycles had 21% lower UTAPIs than spontaneous conceptions. However, preeclampsia incidence was higher, 3% versus 1%. Donor 2025 found the same patterns with more than 27,000 pregnancies. Compared with natural cycles, frozen artificial cycles had about 21.7% lower UTAPI. Fewer women were classified as high risk, 7.8 versus 1.6%. However, the preeclampsia incidence was still higher, 5.3 versus 1.6%. Donor 2026 showed us this lower UTAPI pattern continue into the second and third trimester of pregnancies. Preeclampsia incidence also remains higher in frozen artificial cycles, 5.2 versus 1.1%. Together, these findings suggest that low UTAPIs in frozen artificial cycles may reflect the effect of early hormones administrations for endometrial reparations, rather than truly the low preeclampsia risk. Our study has several strengths. It includes a large sample size with more than 4,200 pregnancies and more than 1,000 frozen artificial cycles. UTA, uterine artery Dopplers, and first trimester preeclampsia screening were also performed using a standardized protocol. However, because this was a retrospective single-center study, the residual confounding factors cannot be excluded. Other limitations include month comparison groups with few preeclampsia cases and no second or third trimester UTIPI assessment. In conclusions, frozen artificial cycles were associated with significantly lower first trimester UTIPI. However, despite lower UTIPI and more frequent aspirin use, preeclampsia incidence remains higher. Future preeclampsia screening models may need conception-specific UTIPI reference range or corrections factors in order to avoid underestimating the risk in frozen artificial cycles. And thank you for your attention.
We have 3 minutes for questions from the floor. Any questions from the floor? No questions? May I question? How do you explain that the fact that even acknowledging that pulsatility index is lower with artificial cycles, we have 3 times more preeclampsia with artificial cycles? This apparent paradox, I mean.
Yeah, I think the preeclampsia's pathophysiology is very complicated. We actually still do not understand the whole pictures of how preeclampsias come to exist. But UTIPI is only one factor contribute to that pathophysiology. Many other factors, such as the endometrial environments, the early placentations, the androgenic imbalance, or the endothelial dysfunctions, can contribute to the pathophysiology of preeclampsia. So one thing that, even though UTIPI is lower, these frozen artificial cycles actually have no corpus luteum. And that factor can contribute to, has more powerful contribution to the pathophysiology of preeclampsia. So I think that's the reason why preeclampsia rate is still higher, even though the UTIPI is low.
Thank you. And what is your current practice, policy practice nowadays? I mean, do you perform embryo transfer, frozen embryo transfer in artificial cycles or natural cycles? Nowadays, which kind of cycles do you use for frozen embryo transfers?
Can you repeat the questions?
Yeah. Do you prefer nowadays, do you use natural cycles instead of artificial cycles nowadays in your daily practice?
I think you can look at the data from a hospital that you can have your conclusions that most of the frozen embryo transfer cycle in our hospital is artificial cycles. Even though the risk of preeclampsia is higher, frozen artificial cycles still have its many benefits. For example, like they have the schedules for frozen embryo transfer is still more convenient for some patients because they have many other things to prepare when they want to be pregnant. Also, the considering the protocol of preeclampsia screening and prevention nowadays with aspirin administrations, we can still try to identify early in the pregnancy the patients with higher risk of preeclampsia in order to individualize the specific protocol to prevent that happens in a later pregnancy. So,
Thank you.
this is my answer.
One question, do you do egg donation in hospital?
What?
Egg donation. Do you
Donation? Yes.
Yes. Because I saw that your mean age was 30 to 32, so I was wondering if you included these sectors in the study.
Yeah, we included egg donations populations.
Okay, it was included in the study. Okay.
This statistic.
Okay. And the decision to give aspirin, was it because of the result of the screening, or could be also for other reasons?
It was because of both. Even though the breakfast screening protocols suggest that women with the risk greater than or equal to 1 in 100 should receive aspirin as part of prevention strategies. Many doctors still think that, for example, if the patient has done complication with aspirin, or they have, for example, the consultation, the explanation from the doctor to the patient is not good enough to convince the patient to take aspirin. They may worry about the side effect or the therapeutic factors of aspirin. Some know that aspirin is bad, but to some patients, they say you don't have enough information to believe in the medication. So, yeah.
Thank you.
Thank you.
We asked the second speaker of this afternoon to join us on stage. Archer, please, the floor is yours.
Thank you, and thank you for the meeting, giving me the opportunity to present today. My name is David Arce, and I'm an MD. I'm going to tell you about our study called Fetal Growth Trajectories after conception with medically assisted reproduction and nationwide cohort study. These are my disclosures. Now, first of all, why does conception type matter? As you all know, the use of medically assisted reproduction has been increasing since its introduction. Some studies have also reported that there are differences in birth weight depending on the type of medically assisted reproduction used. For frozen embryo transfer, a higher mean birth weight and an increased risk of children born larger gestation age has been observed compared to natural conceptions. Fresh embryo transfer, a lower mean birth weight and an increased risk of children born small for gestational age has also been observed compared to natural conception. This is also what has been seen in intrauterine inseminations. Now, why does this matter? Well, there are some risk factors with deviating from expected birth weight. Having a child being larger gestational age may increase the risk of postpartum hemorrhage, longer postpartum hospitalization, and also cesarean section. Also, for children born small for gestational age, there might be an increased risk of neonatal hypoglycemia and hyperbilirubinemia. Later on in life, high and low birth weight has also been associated to some risks. These include an increased risk of type 2 diabetes, cardiovascular disease, and obesity. So we know that there are some changes to birth weight, but we don't know much about the fetal growth before, and this led us to our study question: do fetal growth trajectories differ after various methods of medically assisted reproduction? So we conducted a population-based cohort study using Danish national registries, where we used the maternal ID number to link mothers across registries on an individual basis. So our study period was from 2008 to 2018. We used the Danish Medical Birth Register, which contained all the information about the mother and the birth itself, the Danish Fetal Medicine Database, which contained all our ultrasound information, and lastly, the National IVF Registry, which contained information about the treatment. So we ended up with a cohort of around 500,000 singleton pregnancies, where 5.4% were after medically assisted reproduction. Our primary outcome was to assess fetal growth, which we did longitudinally at 3 different time points. The first was during the first trimester, where we used crowd rump length as a matter of assessing fetal size. Then, during the second trimester, we used estimated fetal weight, which was calculated based on ultrasound observations and then the Hadlock formula. And then lastly, at birth, we of course used birth weight. We then compared our observations to real-world reference curves so that each observation was compared to a reference size at the exact same gestational age. Our study groups were as follows: frozen embryo transfer group, fresh embryo transfer group, intrauterine insemination, and lastly, natural conceptions. We also excluded observations with multiple pregnancies, as our reference curves were only for singletons. Stillbirths were also excluded. Outliers of a C-score for fetal growth being either below -4 or above 4 were also excluded. This was done to negate any typing errors in the registries. Then conception method mismatch between registries to make sure that each observation was allocated in the correct study group. Also, maternal age below 18 years or above 47 years were excluded, as this is the age period where fertility treatment is offered in Denmark. And then lastly, when we had to finalize our analytical population, we also excluded observations with missing data to calculate gestational age. So we ended up with a final analytical population of around 448,000. Now, when evaluating fetal size, it's very important to determine precise gestational age. And to avoid masking early growth differences, we couldn't just estimate gestational age on the crowned rump length-based dating. So instead, we based gestational age on either last menstrual period, or we calculated based on conception for the medically assisted reproduction groups. So for the natural conception group, we just used their self-reported last menstrual period as gestational age day 0. For the intrauterine insemination and fresh embryo transfer groups, we knew the date of insemination and oocyte retrieval, and therefore the date of conception. So we subtracted 14 days from here, and we called that our calculated last menstrual period, or again, gestational age day 0. Now for frozen embryo transfer, we either subtracted 16 or 19 days from the embryo transfer date. And this was done for both if it was a cleavage stage or a blastocyst stage transfer. And we had to infer that based on the cryopreservation method used, because we didn't know the exact culture duration. Now for some results. So it's important to highlight that this is a distribution of fetal growth C-scores from first trimester until birth across conception groups. So the dots you see is a median, and then you see the interquartile ranges. First, I want to highlight our natural conception group. It's very close to the 50th centile, meaning a C-score of 0. That meant that our own natural conception group was very similar to that of the reference curves, which is of course very good when we try to compare our other groups later on. If you look for the frozen embryo transfer, fresh embryo transfer, and intrauterine inseminations during the first 2 trimesters, you see that they're above the 50th centile, meaning a positive C-score at this point in pregnancy. Now, during birth, it's only the frozen embryo transfer that continues to have a positive C-score or be above the 50th centile, while fresh embryo transfer and intrauterine insemination are now below this line. We, of course, also made some adjusted analysis, and we adjusted based on factors that could influence fetal size. This includes maternal age, BMI, parity, fetal sex, smoking, and pregestational diabetes. So what we did was that we used each group-specific percentage deviation from our reference curves, and then we took the contrast between the medically assisted reproduction groups compared to our own natural conception group. And as you see in the first trimester, they're all positive, meaning there was increased fetal growth in the first trimester for all medically assisted reproduction groups compared to our own natural conception group. This is also what we saw during the second trimester, and these were all of significant value. Then at birth, we saw that the frozen embryo transfer had increased size compared to natural conception, and fresh embryo transfer had now decreased size compared to natural conceptions, both of them being significant, while the intrauterine insemination group was no longer significantly different compared to our natural conception group. What you've just seen in the table is also what's illustrated in the graph here. You see from the first and second trimester increased fetal growth across all medically assisted reproduction groups compared to the natural conception group. Then, during the third trimester, there's a divergence in these trajectories, resulting in increased birth weight for frozen embryo transfer and decrease for fresh embryo transfer, and no significant changes for the intrauterine insemination. Of course, one could consider that the missing laboratory data we had regarding exact culture duration was a limitation. However, we did also conduct a sensitivity analysis looking at only blastocyst transfer or only cleavage stage transfer, again based on the cryopreservation methods, and we saw similar results to what I've just showcased you. Also, we were missing endometrial preparation protocol used in the frozen embryo transfer cycles, so we couldn't see if there was a specific type of endometrial protocol that had a bigger influence on fetal growth than the rest. So to conclude, we saw increased fetal growth across all medically assisted reproduction groups already from the first trimester, and we saw it throughout the second trimester as well. Then there was a divergence in growth during the third trimester, resulting in increased birth weight for frozen embryo transfer and decreased birth weight for fresh embryo transfer, as previous literature has also suggested. Of course, further research is needed to clarify the mechanisms behind these changes. We know that other groups are looking at possible mechanisms, and we have also initiated the COMPARE study, looking at conceptions after ART and natural conception, comparing fetal size and collecting blood samples, examining the placenta, and also the health of the child afterwards. And lastly, I would like to thank my study collaborators, and thanks to Novo Nordisk Foundation and Merck for making it possible to be here today. Thank you.
Are there any questions? No. Do you have any clinical advice based on these results?
I mean, yeah, we saw some differences, but of course, the absolute risk is very low. So I don't think we have any conclusive material here, but it's of course important to evaluate also because it could influence the health of future generations. But as of now, I don't think we have any practical recommendations for that. Yep.
And this is please.
Thank you for the wonderful work. Do you have any idea regarding the mechanism that might cause this?
There are some theories regarding either the cryopreservation method in the frozen embryo transfer group, which may influence some epigenetic changes that could occur to increase growth, and also this amount of ovarian stimulation that happens in the fresh embryo transfers, that could influence the trophoblast invasion and even later on the placental development, which may cause some of these differences.
And this is maybe more curiosity and admiration, of course, from the National Registry. Whenever you have a pregnant woman, regardless on the conception way, you register the way she got pregnant. I mean, one of the group was spontaneous conception. You had the last menstrual period, so all of the information of a pregnant woman are registered in the National Registry.
Yes, so the registries contain this information, and we could link based on the date of birth, and we could see which cycle was associated to that in the IVF registry later.
So they go to the hospital, whatever hospital, and they are registered, and even if they change hospital or whatever is happening, it's always possible to link the information.
Yes, it's linked on a personal ID number that is given to every resident in Denmark. Yes.
Yeah, wonderful. Please.
Ann Steiner, USA. Thank you for this work. My question is just about dating of the pregnancies, comparing the MAR to the spontaneous conceptions. Did you have any information on when conception occurred or ovulation dates in the group that were spontaneous conceived, or was this all based on first trimester ultrasound, or what kind of?
So for the natural conceptions, it was their self-reported last menstrual period that we had in the registry. And we couldn't use the gestational age based on the crown rump length that you do at the first trimester, because then we would miss the growth from conception until first trimester. However, we also did conduct an analysis where we used the date from given at the first trimester, and we saw similar results to what I've just showcased you actually.
I just think it would be, I'm assuming that all of the MAR pregnancies were dated on actual conception when it occurred and your LMP based, you may have some disparity there in growth, and mainly based on differences in dating.
I mean, yes, of course, there are some, it's not always a precise date that is reported if it's self-reported, but it's the best that we had available for that, to be able to look at the first trimester growth.
Yes, I mean, it's not just an incorrectness on reporting, but time to ovulation is going to vary significantly, and there are going to be many factors that are associated with different growth trajectories, such as maternal age, obesity, that are going to influence time to ovulation. So might be something to try to tease out there in the future.
We will try. Thank you very much.
We have another question here, please.
Vegetti from Milan. Thank you for the beautiful presentation. If I understood correctly, you don't have any data about the endometrial preparation, if it was natural or medicated cycle for the frozen embryo transfer. And do you think that there is a difference between the risk of small gestational age or large gestational age using a natural cycle instead of a medical prepared cycle for transfer?
Yes, I mean, there could be, I mean, using the hormone replacement has been observed to maybe increase the size. So I think that that's definitely a possibility. Unfortunately, just in our study, it wasn't reported in the registries. But I think that, yes, there are probably differences based on the endometrial preparation protocols, which other studies may be able to highlight more precisely than ours.
Thank you.
Thank you very much. Congratulations for your work.
So, moving on, the third presentation, entitled Age Limits for Safe Pregnancy in Outside Donation Maternal and Neonatal Complications Beyond Natural Reproductive Limits, presented by Bolscava from Italy.
Good afternoon, everybody. Thank you for introduction. Today we'll present the results of our prospective study evaluating whether a clinically meaningful age threshold exists for safe pregnancy after oocyte donation. I have no conflicts of interest to disclose. Why is this clinically relevant? Oocyte donation has become an integral part of assisted reproductive technology and allows pregnancy well beyond the natural reproductive age. In Italy, the mean maternal age of women undergoing oocyte donation reached 41.8 years in 2023. While donor oocytes successfully overcome ovarian aging, they do not reverse maternal physiological aging. Therefore, maternal age may still represent a major determinant of pregnancy safety. This led us to a simple but a clinically relevant question. Can donor oocytes overcome the biological limits of maternal aging, or does a maternal age threshold still exist beyond which pregnancy can no longer be considered reasonably safe? So how old is too old? To answer this question, we conducted a prospective study, cohort study, including 550 singleton pregnancies achieved through oocyte donation between May 2015 and August 2024. We included only singleton pregnancies in order to minimize confounding effect of multiple gestations. Patients were stratified into 4 maternal age groups. Baseline maternal age, a paternal age, and BMI are shown on the right. It is also important to note that both maternal and paternal ages were relatively high in our cohort, with a mean maternal age of 41.2 years and mean paternal age of 43.5 years. However, the maternal age was consistent with the Italian national profile of women undergoing oocyte donation. We then evaluated the major maternal and neonatal outcomes. Just a second. When pregnancies were stratified according to maternal age, a clear pattern emerged. Maternal complications increased progressively with advancing age, with the first significant escalation occurring after the age of 45. Gestational diabetes almost tripled. Preeclampsia increased nearly fivefold, and postpartum hemorrhage became particularly frequent in women aged 50 years or older. Overall, maternal morbidity increased substantially with advanced maternal age. We then analyzed neonatal outcomes. Preterm birth became more frequent in women aged 47 to 49 years, whereas neonatal intensive care admission increased progressively with maternal age, reaching almost half of newborns in women aged 50 years or older. Interestingly, fetal growth parameters, including UGR, SGA, and LGA, remained remarkably stable across age groups. Therefore, the main neonatal consequence of advancing maternal age was an increased need for intensive neonatal care, rather than impaired fetal growth. We then focused on women older than 45 years. Although complication rates were already significantly higher in the 45-46 year group compared with younger women, they increased even further beyond the age of 47. Among women aged 47 to 49 years, 1 in 3 developed gestational diabetes and 1 in 4 developed preeclampsia. In women aged 50 years and older, 1 in 3 developed gestational diabetes, 1 in 3 developed postpartum hemorrhage, and 1 in 4 developed preeclampsia. These findings suggest a progressive loss of maternal physiological reserve with advancing maternal age. Finally, we analyzed the mode of delivery in women aged 45 years or older undergoing oocyte donation. Overall, cesarean section was the predominant mode of delivery, accounting for 85% of all births. Approximately 2/3 of C-sections were were planned, and while 1/3 were performed as emergency procedure. The leading indication for emergency C-section was labor dystocia, according for 45% of cases, and it included failed induction of labor, arrest of labor progression, and cephalopelvic disproportion. It was followed by preeclampsia and fetal distress, each representing 16%. These findings support that pregnancies achieved through oocyte donation after the age of 45 should be managed as high-risk pregnancies. In conclusion, maternal and neonatal morbidity increased markedly after the age of 45, with the greatest burden observed among women aged 50 years or older. Although this subgroup was small, the consistency of the findings across several clinically relevant outcomes support the necessity of particularly careful counseling, close surveillance, and coordinating specialist care. The pregnancies after 45 years should therefore be considered high risk, and the managing should begin before conception through the comprehensive counseling and optimization of modifiable cardiovascular, metabolic, and general health risk factors, and continuing throughout the pregnancy in tertiary referral centers. Ultimately, donor oocyte can overcome ovarian aging, but they cannot reverse maternal physiological aging, which remains the main determinant of pregnancy safety. Thank you.
Any questions for the floor? Yeah, on the right.
Hi, it's Sandy.
Hello.
I'm Sandy Starr from the Charity Progress Educational Trust. I'm interested to know if you've done any, or if you plan to do any, anything in the way of disseminating these findings, discussing them in public, discussing them in policy circles. The reason I ask is that we've just published some public opinion research jointly with ESHRE in Italy, Netherlands, UK, UK and Spain.
We can discuss.
Yeah, and although people are very liberal-minded in relation to many things, more people in all 4 countries think there should be an upper age limit for private fertility treatment than think there should not be such a limit. And the age they agree on is 45.
Okay, we agree.
You agree. The catch is that they think that in relation to biological females and males, which adds an interesting complexion to it. But given that that is the state of public opinion, which one may or may not agree with, one might want to change or shape or whatever, but I'm interested to know what you're going to do with this in the public domain, if anything.
We are already in the clinic where the study was conducted at Careggi University Hospital. We already have the service of preconceptional service, obgyn, preconceptional ambulatory, where women that want to apply for oocyte donation procedure, they make the consultation. So they are studied by their metabolic and cardiovascular factors and trying to get better their health. And so that's why we're studying this question. But we hope that it's going to help us to reduce this morbidity. Because this type of pregnancies, it's not only the age, it's also pathology, the type of the BMI, the type of pathology that women already have and accumulated in her life. We have to correct it, and we have to prepare the woman for this pregnancy in the best way. So it's already, we already have this service in Florence.
Thank you.
Yeah,
Michael Awadala, United States. Thanks for the presentation. It's really interesting. It's a topic of great interest. I think it would be helpful, I'm not sure if you have the information in your data set or not, but to include whether or not the woman was pre or postmenopausal, and whether the embryo transfer occurred in a hormone replacement cycle or an ovulatory cycle. Because I think if you look into it, probably the risk is a lot less for a 50-year-old woman who ovulates regularly, is premenopausal, and the embryo is transferred when there's the corpus luteum present, versus if you have a 44-year-old woman who went into menopause at age 35. That's probably a lot different risk. So I think it'd be very difficult for me to tell a 50-year-old patient who has regular cycles that she's too old for us to do a transfer when she still ovulates regularly. So I think those would be helpful, especially with relatively strongly worded conclusions. You really want to make sure those risks apply to all groups above that age, and then it's not just dependent on menopause and if it was an HRT or natural or modified natural transfer cycle.
Thank you for your comment. I don't have the data of if they were in menopause or if they had cycles, but the most part of the cycles were prepared with with the artificial cycle. But noticing the 50 years old patient, we're not talking only about the corpus luteum, we're also talking about the aging of endometrium. And so obviously if you have all the factors that are produced by corpus luteum, you're happier because you feel safer and you feel more natural, but there are another factors that may influence on these outcomes.
Thank you very much for the great presentation.
Thank
Great
you.
data and very informative. I work in the UK, so we have got a different model in terms of NHS funding for patients. We allow funding for up to the age of 42.
Okay.
So by definition, all those patients will be outside our funding criteria for treatment. So probably they self-fund and they come back for obstetric care. And the urgent question is, who should pay for their obstetric care, which is high risk by definition, as you said. So in your country, do you pay for them for the obstetric care? And this is just a question for everyone to think about.
Yes, we have to remember about our colleagues that work in the delivery room that will meet this patient that have to do maybe a C-section at 3 in the night, and so we have to do our best to prepare this patient and to make her arrive to the pregnancy in the best health situation. And no, we don't have the refund of the patient don't pay for delivery. Otherwise, she wants to do the delivery with some doctor in private clinic, but no.
The last one.
Do you know the indications of your patients for oocyte donation?
Okay, from the oocyte donation were proceeded when there were no possibility of the use of own oocytes. So the causes, they are in the indication of
Mature ovarian failure.
Yes.
But for the previous question, most of your patients in this situation should be in menopausal situation. Maybe they are getting the ESHRE medication or some kind of added treatments.
It's for the patient who has the menopause or ovarian insufficiency. It's better for her health to have the accuracy and to in order to get better her cardiovascular health, to prepare better, and also in collaboration of the group of maternal medicine of preconceptional health, we also considering to make them see cardiologists with ultrasound of heart before pregnancy in order to be ready to everything.
Sure,
Okay.
thanks for your
Okay,
result.
we have to move on. Okay.
Thank you. Thank you very
Thank
much.
you so much.
We invite Dr. Sumunku Johansen to join us on stage. Please.
Thank you for the introduction, and thank you to the ESHRE committee for the opportunity to present our work here today, titled Progesterone Luteal Phase Support in the Modified Natural Cycle, Frozen Embryo Transfer among Women of Advanced Reproductive Age or Low Ovarian Reserve. And the trial was supported by an independent research grant from Gideon Richter. There are several ways to prepare the endometrium for a frozen thawed embryo transfer. And one of the more commonly used protocols is the modified natural cycle, which can be offered to women with a regular menstrual cycle. And in the modified natural cycle, we follow women with transvaginal ultrasound scans until the dominant follicle typically reaches 16 to 17 millimeters or above. And then ovulation is triggered, typically with HCG. And then the embryo transfer can be timed accordingly, and then pregnancy tests can be performed later. In this treatment cycle, the women have a corpus luteum and therefore have endogenous progesterone production. However, many clinicians still prescribe progesterone as luteal phase support on a regular basis. However, a recent systematic review and meta-analysis did not find an improvement in live birth rate with progesterone as luteal phase support in this treatment cycle. And the last study that you can see in the meta-analysis by Saubstel and colleagues was initiated at our clinic. And it was a randomized controlled trial where women were randomized to receive either progesterone as luteal phase support or no luteal phase support. And it did not find an increase in live birth rate with the use of progesterone. However, these results did make us wonder, are there any specific subgroups of patients that might benefit from progesterone as luteal phase support? So we wanted to take the data and look into if we could identify some subgroups, and we chose to specifically look at women of advanced reproductive age and women with low ovarian reserve, as those two groups are associated generally with poor treatment outcomes. So the results today are secondary analyses of a randomized controlled trial, which was previously registered on clinical trials. And it was a Danish multi-center randomized controlled trial that took place at 8 public fertility clinics across Denmark. And the study inclusion was between 2019 and until March 2024. And we included women who underwent modified natural cycle, frozen embryo transfer, and were randomized to receive either progesterone or no luteal phase support. And here you can see the inclusion and exclusion criteria for the randomized controlled trial in general. And I would just like to highlight the age limit, which was between 18 and 41 years. And that they, of course, had to have a regular menstrual cycle and a good quality blastocyst. Good. So when women were included in the study, they were included at cycle day 2 to 5, and then they were followed throughout their follicular phase with transvaginal ultrasound scans. When the dominant follicle reached 17 millimeters, ovulation was triggered with a high-dose HCG, and that this was the day of randomization. If they were randomized to receive progesterone, they initiated it 4 days after ovulation trigger, and all the women had a blastocyst transfer either day 6 or day 7 after ovulation trigger. 16 days after the ovulation trigger, a pregnancy test was conducted, and in case of a positive pregnancy test, they were scheduled for an early pregnancy scan at gestational age 7 to 8 weeks. And if they were prescribed progesterone, they continued until gestational age 8 plus 0 weeks. And then we followed them through the live birth, which was defined as a live birth above gestational age 22 weeks. So for this specific study, we looked into subgroup analyses. And as mentioned before, we defined 2 subgroups. So the women of advanced reproductive age was defined as an age above, from 37 years and above. And then we defined women with low ovarian reserve as an AMH below 1.5 nanograms per milliliter, which was the reference value in the Bologna criteria. And then the primary endpoint was the live birth. And the results that we're presenting are risk differences with 95% confidence intervals. And then we also looked at the entire cohort and did logistic regression models with interaction terms to assess effect modification by age and AMH on the luteal phase support. So we had 610 women randomized in total, and 602 had a blastocyst transfer. And out of those, we identified 145 women who had the age of 37 and above, and 47 women with an AMH below 1.5. And now for the results. So the baseline characteristics for women with advanced reproductive age, they were quite similar across different parameters. They had similar BMI, similar parity, and number of previous IVF cycles, and also if it was day 5 or day 6 blastocyst that were vitrified. They did differ in the age group, so they were slightly older in the progesterone group. And now for the reproductive outcomes. So when we look at the live birth, we can see a risk difference of 9.3 percentage points in favor of progesterone. However, as you can see by the confidence intervals and p-value, it was not statistically significant. And when we adjusted for age, it increased slightly, but still did not reach statistical significance. And the other reproductive outcomes were also insignificant. And now when we look at the entire cohort of 602 women who had a blastocyst transfer, we plotted the predicted risk differences in live birth associated with progesterone across maternal age. And values above the dotted 0 line would indicate a higher predicted probability of live birth with progesterone, while values below 0 would indicate a lower predicted probability. And although you can see a tendency towards an increased estimate with age, it was not statistically significant, as you can see highlighted by the gray area, which indicates the 95% confidence interval. So based on this results, we did not see a clear age-dependent effect of progesterone on live birth. Now moving on to the other group, which was women with low ovarian reserve, we can see that in baseline characteristics, they were also quite similar. In the parity, they differed a little bit, but it was not statistically significant due to the low number of events in total. And when we look at the reproductive outcomes, we see a negative risk difference of minus 21.2%. But as you can see from the confidence intervals, they are quite wide, and the p-value is also not significant. And you can see, or I would also like to highlight the few number of events in this group. And now when we look at the entire cohort again, we see the same as before in predicted risk differences, a more tendency towards an increase of effect with the higher the AMH, the more effect of progesterone, but again, very wide confidence intervals and not statistically significant. Of course, there are limitations to these results. Even though data are derived from a randomized controlled trial, these are secondary analyses on a subpopulation, so no power calculations were made. And because we chose 2 subpopulations in the cohort, there are a very low number of events, especially in the AMH groups, so there might also be a lack of power. And then we also did not have the age at blastocyst vitrification available, only the age at blastocyst transfer. So to conclude, progesterone as luteal phase support did not significantly increase the live birth rate in women of advanced reproductive age or women with low AMH undergoing modified natural cycle frozen embryo transfer. Lastly, I would like to thank all of the participants in the study and all of the contributing clinics, and also thank you to Gideon Richter for supporting the randomized controlled trial with the independent research grant. And I would now be happy to accept any questions that you might have.
Thank you very much. Do you have any questions, please?
Hi, Alexander from Norway. Thanks for finally delivering a study on luteal phase support and frozen embryo transfer, as we are all giving progesterone, but the evidence is low. I was just wondering if we really look at the right subgroups here, because when you exclude all the patients above 41 and you exclude those with irregular cycles, you're now looking at the good prognosis patients, even though ovarian reserve might be low, which might not benefit it. And the question towards that, you use 300 milligrams of progesterone in the luteal phase, if I'm rightly informed. Do you think that does reflect the normal current clinical practice that you see all across Europe?
I think it does reflect the clinical practice that we see in our clinic. So, but of course, in the world, that's a different situation, or in Europe. So in our clinic, we are a public clinic, and the regulations in Denmark are that we can treat patients up until the age of 40 with ovarian stimulation. So we generally don't do many frozen embryo transfers above the age of 41. We do have some if they have frozen embryo transfers from a treatment when they were younger, but they were not included in this trial. And for the regular cycle perspective, we offer the modified natural cycle to patients who generally have a regular cycle within the frame of 23 days to 35 days. So if they are above 35 days, we would generally offer them a stimulated cycle, either with letrozole or low-dose FSH. And that's, of course, another subgroup with other which should be assessed in a different study. But I think when you point out the subgroups, of course, we could also look into different subgroups, and we would have liked to look solely on women above the age of 40, but in this study, we just had too few women above the age of 40 to present anything meaningful.
Thanks.
Please.
Hi. Thank you for this presentation. I'm Saad from Manchester. So my question is, when considering the decision to go for or forego progesterone supplementation, was progesterone measured the day before embryo transfer? And because we know that there is some evidence about progesterone being less than 30 and miscarriage rate. And if yes, was that part of the randomization or did it affect the decision?
So for this study specifically, we did measure progesterone both at the day of ovulation trigger and also the day of embryo transfer. And we did not, since it was a randomized trial, we did not intervene in spite of what the results showed. So of course, women who received progesterone as luteal phase support, they had a significantly higher serum progesterone values on the day of transfer, but on the day of trigger, they were the same, yeah.
So when looking at that, was there any suggestions that actually, yes, agreeing with the literature that actually supplementing with progesterone when it's less than 30 is helping with the success rate, or?
Yeah, so we did not look into it specifically for this study, but we do have another study that looked into this where we pooled data from 2 different randomized trials. And one of my colleagues have it as a poster actually on the conference. And it did not show clear evidence towards supporting with progesterone as luteal phase support in spite of a low progesterone measurement on the day of transfer.
Thank you.
Thank you. We have one last question here, please.
Thank you. Adam Duval, University of Oxford. Thanks for your talk.
Yeah, but
over here. Do you have data on history of miscarriage in this population? And if so, is that a subgroup that you've thought about looking at?
Yes, so we do have data on miscarriage in this population, and they were not statistically, they did not differ between the groups. And most miscarriages happened from time of positive pregnancy test until early pregnancy test, pregnancy scan at gestational age 7 to 8 weeks, so early pregnancy losses.
Okay, no, sorry, I meant if they've got a history of previous miscarriage and looked in whether women had no miscarriage or one or more, for example, in that subgroup.
Sorry, I misunderstood your question then. We do also have that data, and generally they had low losses. I don't remember the exact numbers, but it did not differ between the groups. And also, if they do have 3 or more miscarriages, then generally we do supplement with progesterone as luteal phase support. Yeah.
Thank you.
Thank you.
Congratulations for your work.
Thank you. And the last presentation titled Preconception GLP-1 Receptor Agonist Exposure in Couples with Infertility Outcomes, a Danish nationwide cohort study, presented by HB Hibbit.
Thank you. And yeah, my name is Catherine Hvid, and I'm a medical doctor from Denmark. And thank you for letting me present our study called Preconception GLP-1 Receptor Agonist Exposure in Couples and Fertility Outcomes, a Danish nationwide cohort study. I just want to acknowledge the funding for my PhD salary for other clinical studies. So in the last decades, we have seen that there are higher numbers of couples needing helpful fertility treatment to conceive a child. And there may be several causes for this. We know that overweight and obesity can affect the reproduction negatively, affecting the sperm quality, ovulation, and a longer time to pregnancy. And we are seeing quite a high number of adults and children living with overweight and obesity. So in 2022, around 43% of all adults worldwide were living with overweight, defined as a body mass index above 25. And 16% of them were living with obesity, a body mass index above 30. And if these trends continues, it's been predicted that in 2050, 2 out of 3 adults will be living with overweight and obesity. In the last decade, there have been a new drug on the market, which have shown quite promising results regarding weight loss treatment and also other kind of diseases. It was originally investigated and approved as an anti-diabetic drug, but it's had several other effects since. And regarding weight loss treatment, the primary effect is that it lowers the appetite and intake of food, and also slows down the emptying of the ventricle, all resulting in a lower intake of nutrients, and by that creating a weight loss. And it has been suggested that perhaps it might be beneficial on the reproduction for both men and women, but it's not been studied that much. Now, one thing, GLP-1 receptor agonists are not allowed to be taken during pregnancy and at least 2 months prior to a pregnancy. And this is a matter of safety because animal studies have shown that it might be reproductive toxic. So all these women that start fertility treatment, they are strongly advised to stop treatment before fertility treatment. And several studies have shown that when you stop GLP-1 receptor agonist treatment, there are an increased risk of a rebound in weight regain and worsen or increasing inflammation and cardiometabolic markers. So all this led to this study where we aim at investigating whether preconceptional exposure to GLP-1 receptor agonist in couples in fertility treatment is associated with the outcomes of treatment. For the study, we use the Danish national registries. And in Denmark, every person is given a unique identification number, and it allows us to linkage all the data across all the registries that we have in Denmark. And we included women and their male partner who initiated fertility treatment for the first time between October 2018 and December 2024. This resulted in a cohort of around 120,700 initiated fertility cycles. And then when we did our analysis in this study, we stratified based on what kind of fertility treatment they had received. So in one group, we have those that had received intrauterine insemination, and then in the other group, we combined those that received in vitro fertilization and intrasitu plasmatic sperm injection. And we defined exposure as the redemption of a prescription of GLP-1 receptor agonist, specifically semaglutide, before initiating fertility treatment for both or either the woman or the man. And they could receive the drug if they had diabetes or using it as a weight loss treatment. And for our primary outcome, we looked at the cumulative intrauterine pregnancy probability following either all IUI cycles, or for the IVF-ICSI group, we looked at all fresh embryo transfers and then all IVF-ICSI cycles, including both fresh and frozen transfers. Then as secondary outcomes, we looked at the numbers of oocytes aspirated with the IVF-ICSI group. Because we use observational data, there are of course the risk of confounders. And to take this into account, we estimated something called inverse probability of treatment weights. And it's a way of sort of pseudo-randomize the data, where you make the two groups, those that are exposed and those that are not exposed, more comparable in all the measured confounders. And for confounders, we chose demography factors, socioeconomic factors, clinical factors such as pre-pregnancy BMI, pre-existing diabetes, fertility course, and also number of prior IUI or IVF-ICSI attempts. When we look at our results, we saw quite an increase in numbers of women and men being treated with GLP-1 receptor agonist before starting fertility treatment. In 2020, 0.0% of women and men were treated, and in 2024, 4.5% of women and 3.2% of men. And around 50% of these men, they continued treatment with GLP-1 receptor agonist after initiating fertility treatment. When we compare the men and women that were exposed to those that were not exposed, we do see, as expected, that they do have a higher BMI, they have a higher rate of having pre-existing diabetes, The women had a higher rate of having PMOS, and the men had a slightly higher age. Then when we look at our results and adjust for all the confounders, starting with the RUI group, we in general saw that male exposure of GLP-1 receptor agonist before RUI was significantly associated with a higher cumulative intra-uterine pregnancy probability. We actually saw a 48% higher probability. And when we look at the IVF-ICSI group, we saw in general that female exposure of GLP-1 receptor agonist before IVF-ICSI was significantly associated with a lower cumulative intra-uterine pregnancy probability. And we saw that when we looked at the all IVF-ICSI cycles, so both fresh and frozen transfers, and it was 17% lower. We didn't see any difference based on exposure when we only looked at the fresh embryo transfers. Then we also saw a slightly lower number of oocytes aspirated following female exposure of GLP-1 receptor agonist before. And then we also did a sensitivity analysis where we only included those that were exposed to GLP-1 receptor agonist within the last 12 months before fertility treatment, and that showed the similar results as I've just shown. There are a few limitations to this study. We don't know the true compliance to the GLP-1 receptor agonists after they redeem the prescription. We assume that they take it when they buy it because it's expensive, but we can't know for sure. And then we have no measurements of weight changes, both after initiating GLP-1 receptor agonist treatment, but also when stopping on it. So there's no way we can adjust for this. So to conclude, we saw quite a large increase in numbers of women and men being treated with GLP-1 receptor agonist before fertility treatment. And there may be a beneficial effect on the reproduction with male exposure prior to IUI, but it also does warn for caution with female exposure prior to IVF-ICSI, as we saw a lower cumulative intrauterine pregnancy probability. We do speculate that these women are strongly advised to stop treatment with GLP-1 receptor agonists before they start fertility treatment, and that may result in a weight regain, worsen inflammatic cardiometabolic markers, and that may perhaps not be the best way to start a pregnancy. And also the time point right after GLP-1 receptor agonist cesarean is more critical when the body needs to adjust to this withdrawal. This is one of the first studies, so of course it needs to be studied further, and we cannot look at any causality that would be needed to be done in sufficiently powered randomized controlled trials. In the end, I just want to acknowledge and thank my supervisor, Professor Henriette Svare Nielsen, and senior researcher David Vestergaard, all co-authors and members of the group. Thank you.
Hello, thank you for this first study of GLP-1. Do you have an idea of the drop-off on treatment because of spontaneous pregnancies?
No, unfortunately not. We don't know that. But that would be very interesting.
Yes, it is.
Because that's also what's been discussed and is also in the media with this Ozempic baby. But we don't know that.
And secondly, if I may, generally men are mostly treated because of diabetes, and women are mostly treated because of obesity. So I think perhaps, do you have any difference in your study too? Because it's not the same population, and indeed the sperm goes much more better if the diabetes is better. And for the women, the fact that they have to stop 2 months before getting pregnant, it may differ the interpretation of the benefit of the treatment.
Yeah, I completely agree. We don't know that of the male, regarding male, if they had received for weight loss or not. We do know it, but we don't have that high number to distinguish between the two groups. So we will need to do a follow-up study to also have a higher number, that one. And I completely agree with the interpretation of the results, because also a lot of the men did continue on the drug, and that might keep improving or keeping the effect at least for the IUI group, and all the women, they had to stop.
Are you studying with tirzepatide now? Because
So-
tirzepatide, the double antagonist, GLP-1 and GIP, are you studying it too?
Not at the moment, but it would be possible. But we need, we're using the registries, so it needs to take some years to get the higher numbers needed to, look at it.
Hello, thank you for your interesting lecture. I'm sorry, I didn't get why the rate is increase in IUI and decrease in the XE, the cumulative pregnancy. Can you explain it to me again? Thank you.
Why it is? Sorry, was the question why it differed?
Yes, for the IUI, the cumulative pregnancy increased and the rate decreased in XE. Can you explain this to me again? Thank you.
Well, we don't know for sure. We are thinking that it's two very different methodology way of getting pregnant. It's more IVF and ICSI is more advanced, and perhaps the effect on the male is more pronounced when they get IUI, and perhaps that may not be as important when you get the IVF ICSI. But it's not something that we know. We are only talking theoretically what is the difference. So it needs to be studied further.
Thank you very much.
You're welcome.
One short question, please.
Do you have any idea when we need to actually stop GLP before IVF stimulation? Like, I know that you don't have a accurate data, but assumption.
We know when they redeem the last prescription, and most of them are close to, I would say, 6 to 3 months before initiating, but up to 30% of the women in our data, they redeem the prescription after, within 8 weeks before fertility treatment. So actually after the 2-month period where they're supposed to not take it. Yeah.
One more.
The last one.
Thank you. Lauren Hoshnau from UK. So I have a question about the exposure. You say that the egg retrieval was less among the females. Do you have the exposure time, like it was like more than 3 months after the last prescription or more than that? Does that affect the numbers of eggs?
We don't have that specific number, and it's because we're looking at the prescriptions, and it's a little bit more tricky because we don't know when they actually take it. And sometimes they can buy it and then buy more of them, but when do they take them? So we're not completely able to adjust for all that. But it would be really interesting to
find it.
Yeah, to find it very more.
Thank you.
30 seconds, please.
Thank you. Thank you for the lecture. I would like to know if you have any data on the intrafollicle count from women using GLP-1.
I'm actually not sure if we have that in the registries. So I will need to look that up to you, and then I can get back to you.
But it's a suggestion because we have doubts on that.
Yeah.
Thank you.
You're welcome.
Okay. Anne, last one.
Yes. Do you have any data about the obstetrical and neonatal outcomes of those patients?
We don't have it yet, but we have them in the registries because the data that will be uploaded to the registries are a little behind. So we are waiting for more data in the registries to have a higher number, but we are planning to do follow-up.
Because there is a fear that there would maybe have an increased risk of diabetes and macrosomia because of the gain of weight. Yeah.
And we also plan to follow up, but there's a little delay in the data on that part.
Thank you very much. Thank you for your work. We would like to thank everyone, every speaker, and every team behind for amazing presentations, and of course you all for the attention.